confusing how to choose your level of constraint in knee arthroplasty. Market forces force us to think in terms of their perspective. But what is the scientific standpoint? How to choose the right implant for your patient who has got osteoarthrosis of the knee? So this video is about the evidence-based perspective on how to choose the right case for a uni. What is the right case for a CR? What is the right case for a PS, PS plus, semi-constraint, a hinge, and a tumor? So we'll look at one X-ray example of each case, discuss the ways to diagnose arthritis of that particular compartment and choose the right implant for that particular knee and be very scientific about our judgment. So let's first look at anteromedial arthritis of the knee, and that's how arthritis truly starts, is from the medial compartment. And this is a common case. Now imagine if this patient is 48, 50-year-old lady with medial compartment pain, the lateral compartment looks very good, the patella looks very good. If you do a PS knee in this lady at 70 will need a big revision. So we need to think as, is just medial compartment away limited to the medial compartment? Do we really need to do a total knee, or should we do something else? The right way to think is that we should do a valgus stress X-ray. And when we do a valgus stress X-ray, the knee opens up medially. What that means is that the MCL has not undergone a permanent contracture. And the disease is because of loss of cartilage. When you give a valgus stress, as you can see here, and the knee opens up, that means that if you put an implant replacing the cartilage part, rest of the knee is quite all right. So your cruciates are all right, your patellofemoral joint is all right. All you have is medial compartment away of the knee, which is primarily due to cartilage loss. Now this is a great case for a partial knee replacement. And you can see here that partial knee replacement just replaces the medial compartment. The lateral compartment is beautiful, patella is beautiful, and the knee is restored nicely to mechanical axis, 1 or 2 degree in varus in a uni, and the cruciates remain intact. One of the ways to see whether the cruciate is intact, the anterior cruciate especially, is to see the lateral concavity of the medial plateau. Now on the lateral X-ray. Now if the medial tibial plateau retains its concave structure, what that means is that the ACL is intact and the knee is not subluxing posteriorly. Because when the ACL is gone, the knee will sublux posteriorly and the medial tibial condyle will flatten out, and that is not a case for a uni. So for a partial knee replacement, ACL has to be intact, the disease has to be confined to the medial compartment, patella has to be good, and the deformity has to be correctable on a valgus stress. Now that's a great case for a uni. Now uni can be of two types, either a fixed bearing or a mobile bearing. Mobile bearing Oxford type of a design has been in there for 4 decades now. Very good long-term data, reasonably good data of about 85% survivorship at 10 years in registries as well. Little high learning curve, but you can always learn and do this because in a young patient, less than 50 years, it's a good operation to do for isolated medial compartment because then all your 4 cruciates are intact, you get excellent range of movement, and uni has to been shown to have the highest forgotten knee scores. What that means is that the patient really forgets that patient has had an operation on the knee. So it's a good thing to learn. More important is to identify the right patient that we just did. Now let's go on when to do a cruciate retaining knee and when to do a posterior stabilized knee. Now when the disease is advanced more than a case of uni, that is the disease has advanced to the other compartments of the knee, the patella is also involved. It is primarily medial compartment, some subluxation is there, the deformity is not much, it is less than 10-15 degrees, which is primarily correctable, especially in a young patient, then that's a great case for a cruciate retaining knee. Now you can do a posterior stabilized knee in all the cases you want, but then the thought process is, should we really sacrifice the PCL and should we really do a posterior stabilized knee in all our cases, or should we think of cruciate retention? The reason we should think is that the long-term survivorship of a cruciate retaining knee is longer than a posterior stabilized knee because there is no box and cam, it's an unconstrained knee. So the maximum unconstrained knee is a uni where all 4 ligaments are intact. Next is the cruciate retaining, when the ACL is gone because of arthritic process, but you retain the PCL and that gives a natural stability to the knee and you don't need a box and a cam. Now when you don't have a box and cam, your knee is unconstrained and will last longer, and that is proved in long-term registry data. So you can see the right case for CR is where you don't need much soft tissue release. You do a measured resection, cut 9 millimeters of tibia and femur and replace with equivalent amount of metal. You don't need much soft tissue release, and you can see here that the knee is nicely mechanically aligned. It's got a nice slope and it's beautifully balanced in extension and flexion. Now let's go into a little bit of detail of cruciate retaining knee. Now cruciate retaining knee has 2 polys, one is standard poly and some companies give you a deep dish poly. Now they say you can take off the PCL and put a deep dish poly. Now that is not really a cruciate retaining knee. Cruciate retaining knee is only when you retain the PCL to its normal structure and function and put a normal CR poly. When you put a deep dish poly, you have to take off the PCL and then it's more of an anterior stabilized knee. So the difference between a CR and a deep dish poly is that when you put a deep dish, it's got more constrained anterior posteriorly, your PCL is insufficient, when this knee is called anterior stabilized. Alright, so that's the difference between CR and anterior stabilized with a deep dish poly. As you can see, there is no box and cam, so there will be no third part wear, and CR knee, if properly balanced, will last longer. Some people find it difficult to balance the PCL, and they say PCL is tight. It's not the PCL which is tight, because PCL is what God gave or nature gave to that particular knee. It's always nice and pristine and beautiful. What is tight is the flexion gap. So one has to give 7 degree slope and downsize the femur in case you're between sizes, so you have adequate 9-10 millimeter space to put your poly. So if you really give a 7 degree slope, and if you cut 10 millimeter of posterior condyles to give adequate flexion space, you'll always be able to put a 9 millimeter poly, and you'll never be in a need to release PCL. So cruciate retaining knee is a good knee to do, good knee to learn, especially in young patients who are expected to live longer. Now when to do PS? I'm sure you all know that. A lot of you do PS knees and some do PS in every case. But as I said, it's important to think when to uni, when to CR, and when the deformity is more than 10-15 degrees, especially the fixed deformity, big posterior osteophytes, a lot of patellofemoral disease, and you know you can't balance the PCL because of the big osteophyte, fixed deformity, you need more soft tissue release. Then it is better to do a posterior stabilized knee. So you know that posterior stabilized knee has a box and cam. And in this particular case, when the knee is very tight, big deformity more than 15 degrees, or big osteophytes near the area of PCL, then you can do a posterior stabilized knee like all of us do. But you can differentiate when to do CR and when to do PS. Less deformity, correctable deformity, CR, especially young patient. There is another constraint called the PS plus. Now that's available in some of the implants, like this particular one, and it gives more constraint than a PS insert. So here you can see this is a normal PS insert, and this is a PS plus insert. Now what that means is it is a little more constrained. It is wider, and it is a little thicker. So it gives a more rotational stability. Now in elderly patients who have been walking on very severe varus deformity, there is lateral collateral laxity and the knee is still a little lax laterally. Then you can use a PS plus insert. But this is for elderly patient because more the constraint, more the wear. So you should remember that you should not use it in every case, but use it judiciously. Only in the cases which have got more lateral laxity, or in a valgus knee severe type 3 where there is MCL laxity in elderly patient, you can use a PS plus insert. So friends, we have seen when to uni, when to CR, when to PS, and when to PS plus. Now let's go to the rest of the 3 constraints. When there is further more instability and the patient is more deformed, as you can see here, very severe deformity, no joint line, regional osteoporosis, big osteophytes, the gap becomes little mismatched, and because of osteoporosis, you need to add stems into it. Then you can go up to the next constraint, which is a semi-constraint type of a knee. And whenever you use a semi-constraint, which is a bigger and a deeper box, you should use stems. And the reason is that the thicker the constraint or higher the constraint, the forces will be transmitted to the implant bone interface. And that's why you should have a load sharing device, which is the stem on both the sides. And here you can see in the post-op x-ray that we have used stems on both the sides. We've done some medial epicondylar osteotomy to correct the deformity, and the deformity is nicely corrected. But because the lateral laxity is big, the gaps are a little bigger, and there is regional osteoporosis, we've used a higher constraint with stems on both the sides. And we should know that stems are load sharing, and there is a particular way to put the stems. You should not put them very tight that they cause end stem pain. You should not put them very loose because otherwise they're no good. You should have enough fixation in the diaphyses of both femur and tibia. And you can use offset of the stem to lateralize the tray. So you can use offset tray in case you have to position your component correctly. So stems not only fix but also influence the position of the component. So if you want to shift your tibia laterally, you have to offset your stem medially. And similarly, femur usually we have to bring down, and that's why you have to offset the stem anteriorly. So this is a semi-constraint, and the semi-constraint LCCK or TC3. We'll discuss in a later on video what is the difference between TC3 and LCCK. There are 2 revision systems, but each has got its strengths and pitfalls or drawbacks. We'll discuss that in a later revision video. But right now it suffices to say that we should use higher constraint in case where there is instability, in case the gaps are bigger and we are not able to balance it with a 15 or 17 standard PS poly. Now, when the collateral insufficiency is more, so you're revising or you're doing a case where there is MCL insufficiency, you can use a hinge. So what happens in hinge is that both the components are locked. So there is a hinge in between, and the right indications for using a hinge are in a primary case is a neuropathic joint or a joint where the gaps are too big, the flexion gap is too big, and you want to constrain it or hinge it, or in a revision case where there is collateral insufficiency. The commonest primary indication is a neuropathic joint, is a hinge joint. Right. So last constraint is a tumor prosthesis, and we all knee surgeons should know how to do a tumor prosthesis. Now, have this case, which is totally done 3 years back. The lady 85 fell down, and this fracture was almost one month old when she presented to us. And you can see there is so much regional osteoporosis, so much comminution here that this fracture will not unite by osteosynthesis. Especially elderly patient 80-85 with cardiac comorbidities. If the patient is on the bed, probably they will have a lot of medical complications. So in this case, you want to mobilize the patient faster, and this is a great case for a tumor prosthesis. And you can immediately take that part off and put in a tumor prosthesis. Now, tumor prosthesis is another step forward to a hinge. So obviously, it is a hinge. Obviously, it is a hinge, no question about it, but you can add spacers depending on what bone you have to resect. So the basic segment could be 5 to 7 centimeters depending on what system you use, and then you can add spacers. You can use uncemented stems in case the bone quality is good, or use cemented stems, especially in elderly patients like this case. You can cement both the stems. So tumor prosthesis, you have to put in the right rotation. External rotation, as per linea aspera, is very important because otherwise patellar tracking will be a problem. So whenever you're doing a tumor prosthesis, be very careful of the rotation of the femur and the tibial component. So friends, the objective of this video was to share with you a scientific-based perspective on when to choose all of these implants based on the level of constraint. The objective is not to promote any implant, but to share the scientific standpoint. And let me now quickly summarize this. So medial compartment osteoarthritis, no fixed deformity, opening up on a valgus stress X-ray, ACL intact is a good case for partial knee replacement. Tricompartmental disease, younger patient, less than 10-15 degree of deformity, especially correctable, is a great case for CR. If the PCL is not intact or is violated, you can do anterior stabilized knee, which is deep dish. PS knee, we all know is a standard knee, but you can use a PS plus insert, especially in elderly where you have more lateral laxity or there is some imbalance of the gaps in extension apart from your doing a meticulous soft tissue release. In revision situations or in more unstable situations, more deformed, we can use a semi-constrained, a TC3, LCCK, but then we should always use stems and use the stems to modify the component position to our advantage. In a neuropathic knee, in a knee which has lost its collaterals, we have to hinge a knee. Again, we have to use the stems on both the sides. And in periprosthetic fractures or loss of distal femur bone, supracondylar fractures post TKA, comminuted fractures post TKA, we can use a tumor prosthesis, cemented or uncemented stems depending on the bone quality. So thank you very much, and I hope you'll find this video useful, especially when you're doing a decision on how to choose your level of constraint for a knee implant. Thank you very much.